All right, welcome back to another PCBH Corner, and I'm joined again by one of my favorite humans, Stacy Ogbeide. I think this is the second PCBH Corner.
I think so. Yeah.
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 What was funny is that Stacy and I, this is what we do before even getting on the corner. We were having a great conversation, and we were like, "Hey, let's record this," because it's the whole
Yes.
point about doing. Stacy, I don't think you need to introduce yourself, but do you want to do a quick introduction for people that might not
Yeah.
be familiar with you?
Sure. So, I'm Stacy Ogbeide. I'm a clinical health psychologist by training and PCBH enthusiast. At least that's how I like to describe it. I am in San Antonio, Texas. So at UT Health San Antonio in the Long School of Medicine. And so I'm in the family medicine residency. I'm actually transitioning out of that role, handing it over to a very capable colleague of mine, another psychologist in the residency. And so I'll essentially just get to see patients and work with residents, which is kind of fun,
Hmm.
that I don't have to do a lot of the organization of curricula, at least for the family medicine residents.
Hmm.
So I still lead the psychology internship, the primary care track. And then I have a new role as assistant dean for faculty for the School of Medicine. So as I transition into my new role, I'm giving some of my other roles to other people. So happy to be here and happy to talk about supervision.
Yeah, and I think before we jump into that, the supervision conversation, my mind just wants viewers to know. I think one another plug to always reach out to people and always talk with people. And Stacy's one of the most gracious people about responding and talking with people. More though about, and Stacy, we've talked about this, how much gratitude I have for you for always kind of redefining and pushing like what role psychologists can have with even like again medical programs and being the assistant dean. Like it's like what the hell are we talking about? Like these incredible positions that if it wasn't for people like you, psychologists or even behavioral health providers just in general wouldn't even be in the conversation for us. So I just
Yeah,
really want to express my gratitude for that. And if people are thinking about careers in academia and both, I would also say clinical. I mean, just across the board, you do everything.
yeah, you do.
Stacy is
You
your
do.
person to reach out to. Okay, so what prompted this PCBH Corner was Stacy has put out, and we're going to put the link into the description here at the bottom of the video, the collaborating with CFHA, this incredible PCBH supervision modules and trainings. And so the one thing that my mind wanted to ask from the beginning, Stacy, is where did it come from? Like why, what was the motivation? What was kind of the idea behind like, hey, let's do some modules, not only just about supervision, but particularly within PCBH.
Yeah. So interestingly enough, so as I mentioned, one of my roles, I am the primary care track coordinator for our psychology internship at UT for some years now. And one of my frustrations, which I'm curious if other people have these frustrations, is that, during the interview season, I would ask potential candidates, what's your experience in primary care? Or, I'd see on their CV, they did a rotation in a primary care setting. I'm like, great, tell me about it. And they'd say all the things, that someone who's putting together a rank list would likes to hear. And so I'm like, oh, okay, great. They're saying warm handoff. They're saying patient and not client, the visit, and they're using the terminology. They know what an A1C is. Like, this is great. This is great. And then they'd match to us, and then they'd come in clinic, and I'm like, great. You come with a PCBH background. Let me observe you do a visit. Like, let's kind of fast forward, through some of the shadowing I typically do with folks who are new. And it's, deer in headlights, or they don't know what a contextual interview is, or they don't know what a functional assessment is. They've never really done targeted interventions. They're talking about treatment plans, all these things that, let me know, okay, what you define as primary care work and how I define it is quite different. And what I found was fairly consistently, the learners had exposure in co-located care.
Mm.
And there's definitely nothing wrong with co-located care, but that's not what I do. That's not what my area of expertise is. That's not what we do at our sites. We practice full scope
Mm.
primary care practice. We're generalists. We see ourselves as primary care clinicians,
Mm.
which is an identity shift. And so once that happened, at least another like a third year in a row, I said, okay, this is okay. That's when I said I need to do something to put out to the masses, so we're all on the same page of how we say we're training people. So that's honestly where it came from, was my frustrations with getting learners where I'd have to undo a lot of what they were taught to redo it, to really help them understand what primary care is, what are the basic tenets of primary care practice, to see themselves as primary care practitioners, not behavioral health individuals in primary care.
Stacey, something subtle within that I love so much. Again, another point for people watching this is like, there's always going to be these frustrations that we get to as like directors and just the different things. And I love, again, it's one of the things that I covet about you is like, you're not going to accept the premise, right? Like, you're not going to accept like, this is just how it is and stuff. It's like, no, like, we're going to do something about this, right?
Yeah,
We're going to put a training out.
We're going to do something. Yeah.
So I love the subtlety of that it's like, if there's something that is like frustrating that you're seeing, and that it's like, I'm not going to accept this to be true. Like I'm going to do something about this. So that is really badass. So let me ask you this. I mean, what do you think? My mind has so many different questions. The first one is more of a broad one. What do you feel like is different about just regular supervision, and then when we start to place it into PCBH, what do you think separates that? What are you trying to really train supervisors to make sure they do within a PCBH context?
Yeah, I think the biggest difference is the fast-paced nature of life in primary care. And so if you think about our traditional behavioral health models of supervision, where you meet once a week for an hour, maybe two, it's very macro system focus or micro system focus, where you're talking about patients or clients, if we're using the terminology that they use. And you're not really talking about the macro system issues. How are you functioning within your team? How's your confidence with talking to PCPs or to the pharmacist or to the dietitian? You're not talking about those things. And so in primary care, if you wait till that weekly sit down to discuss, so many things would have happened in a learner's experience. Even practicum students who are there just 1 or 2 days a week, so many things can happen within one day that you kind of miss your opportunity to give a teachable moment to a learner who is really nervous to disagree with the PCP. And how do you model respectfully disagreeing with a colleague to make sure the person in the center of this, the patient or the family, gets what they're seeking or what they need. And so I feel primary care is different in that we need to capitalize on these in vivo moments that oftentimes traditional behavioral supervision misses, because either the supervisor's not on site to even see that, or you have to wait until Friday, and it's Tuesday, and you're and life happens between Tuesday and Friday. So
this is why I love doing PCBH courses. Really, this is just for my development. There's no other reason for this. It's just a selfish thing so I can learn about stuff. The thing that I love that you said, and two things on my mind went to that you just did such a good job of explaining something that I feel like I felt but wasn't able to describe. One is like, there was such a different skill set. Like, yeah, there's a clinical skill set. There was no doubt about this clinical skill set that really transcends like probably any form of psychological interventions supervision. That there's that clinical skill set. PCBH is super unique because almost like to an additional level of importance, there's this systems part about how you work. Like that is really, really profound about how you kind of like describe that. And then with us being so like, it's a reflective process with supervision, it's not happening in the moment when these things are occurring. And so that's something I wanted to ask you about, because Stacy was able to come out and do a great supervision training with our supervisors out in the Cascades region of NPTC. And one of the key components that you talked about was precepting. This is
Yeah.
a common
Yes.
thing for, family medicine residencies and residencies just in general in medicine.
Yeah.
Not very common for, behavioral health folks. Can you describe what precepting is, and then talk a little bit about
Yeah.
how you include that not only in the modules, but just in your daily interaction as a supervisor?
Absolutely. So I absolutely love everything about precepting. I think it hits on a lot of different things. It hits on the just in time or the in vivo moments, but also giving a small nugget of information to your learner that they can handle. As my learners tell me, especially in the beginning, it's overwhelming to be in primary care. Overwhelming. And if you're a licensed BHC watching this and you didn't get training in the pre-licensure level stages, you could probably identify with how overwhelming it is to be in primary care. So to take small doses of information, small take-home moments, and really, really reinforce that for your learner is so powerful, and they don't forget it. I promise you, they don't. They don't forget that teachable moment that you're giving them. And so, precepting has been around in medical education forever. Behavioral health, with many things, we're a little slow to the game to pick that up. Nursing has used it, pharmacy has used it, medicine has used it, just about every facet of health science education has used it, except for us. Even psychiatry uses this. So I will give kudos to our psychiatry colleagues. They definitely use this. It's really everyone else in behavioral health has not caught up to this. And so precepting is essentially when you have your faculty member. Sometimes it's called an attending, depending on where you are in the US or outside of the US. It could be your clinical supervisor, but it's the supervisor of record for that clinic session or that day. And they're the go-to person where your learner will go and see a patient, step out of the visit at any given time that you tell them. It could be in the middle of the visit, it could be at the end of the visit, depending where they are in their training experience. And then they give report to you as the faculty member. I saw Jane Doe, 27-year-old female, coming in with a past medical history of chronic kidney disease, major depression, type 2 diabetes, and they kind of go through the patient's story. I think that's the one thing that is powerful for behavioral health folks, is that you get out of this siloed way of thinking about patient care. You think about the whole person. They're not just a person with major depression. And many times in psychology, in marriage and family therapy, in counseling training, you all are taught the siloed pieces of care, which I feel has done a disservice to you. And so when you're able to precept, you really understand, well, okay, so they have chronic kidney disease, they have type 2 diabetes. I wonder how these things are influencing their presentation of feeling tired, fatigued. Is that depression, or is that someone who has a really, really uncontrolled diabetes? So it helps you think through all these things as a learner. You talk it through with your attending. So you go through what you gathered. If you're a contextual interview person, your love, work, play, your 3 T's. And then you talk through, well, I decided to do this intervention with the patient. And then as a faculty member, I'll ask, well, explain to me, using a lot of Socratic questioning, walk me through your reasoning for this. So as a faculty member, I want to know, are they taking what they gathered in the contextual interview and making the intervention contextually based for the patient? And I'll ask them, okay, so you decided to do behavioral activation. Can you walk me through where that came from the contextual? What in the contextual brought that out that you felt that was low-hanging fruit, that you felt I could get the biggest bang for my patient? I felt they would really gravitate to that. You're making the intervention make sense based on what the patient gave you in the visit. And so that's the whole process of precepting. So it's powerful. You learn as a faculty member what your students know and what they don't know. And so that way, for me, in face-to-face supervision, one-on-one supervision, I can then talk through things that I found. Okay, so we need to work on your ACT case conceptualization or your CBT case conceptualization. Or you told me, man, I'm really uncomfortable with getting warm handoffs for medical conditions. So I can use that time for us to talk through, what are the hallmarks of type 2 diabetes? What is CKD? We could talk through those things versus in clinic, we need to move quickly. We need to see patients, get them in and out. So that's what I love about precepting, is that it helps you understand what your learner knows. Your learners feel so much more confident because they're kind of talking through what they know and why they did something. And they're like, and the intervention worked really well, or wow, I face planted, that didn't work well. Help me. And so you get a chance to understand what they know and what they don't know in a fast-paced situation. This process takes about 5 to 6 minutes, which is great for primary care. Patients aren't waiting too long when you're talking it through. So that's the process of precepting. There is a formal model called OMP, 1 minute precepting, that a lot of medical educators know about and use. So my hope is that we can build this skill for behavioral health providers, because this is the future. This is, if we want to do more interprofessional education, train the masses, meet the workforce needs, we need to train differently.
Stacy, and if people are, watching this and they're intrigued, this is why we're doing it. It's like, go get the modules and go through the training.
Yes.
Because I think one of the things that's really profound is what you just described is like the benefits of precepting. We just onboarded, as most people are onboarded, our new class of doctoral interns. Every single scenario, what you described, like we saw that someone was like, hey, I've never really worked with someone with high blood pressure. It's like, okay. And what's interesting, as you said, it's almost like a stimulus control to actually identify things that you're going to talk about in supervision or to grow within supervision. Because how often, like again, you're just describing this. So how often in primary care, it's just busy, and even like a trainee, no fault of themselves, they forget things that happen and
absolutely.
that they want to go over. Like, that is just so freaking cool. That is awesome.
Absolutely.
Let me ask you this too, because one of the things I took away from your training that I loved, and it's always my mind, I always struggled with this, is, and I never thought of precepting this way, and I love how you describe this, is this balance of recognizing how much you need to know within primary care and still having someone have confidence in themselves. And primary care, it can humble you so freaking quickly.
Very quickly.
Very, very quickly, right?
Yeah.
And it's cool how you labeled and you described that precepting almost allows you, well, yes, identifying growth areas, also simultaneously having more touch points to build up confidence within and I don't know if there's even a question in there. Can you talk to that more about how you've seen that play out? And
absolutely.
Yeah.
Well, I've definitely seen, especially we're in August right now. Our psychology intern started in July, so they've been there for a little over a month. And I think after 2 or 3 weeks, the first thing my intern said was, "Wow, I don't know anything." And it was fascinating because I think she does know quite a bit. She comes with a very good, and maybe she'll watch this and know I'm talking about her. I think she's very well trained. But so on one side, yes, I think she's well trained, but on the other side, I do agree. Yeah, you don't know a lot about primary care. That's why you're here. And so that's why I love precepting, because for me, the confidence comes from, one of the first questions we ask in precepting when they come back, we ask, what would you like to do with the patient? What would you like to do? And it really gives them ownership of the plan. Especially early in the year, they're very much like, well, you tell, her first reaction was, well, will you tell me what you want me to do? And I said, no. You tell me what you'd like to do to help this patient, and really giving them coaching. So really the plan is theirs. You're there, it's almost, I think of in theater, if people know about improv, you have a side coach sometimes on the side of the stage, where you can get feedback from, but ultimately you on stage, you're the one kind of leading the plan. And so I like to see us in medical education as side coaches, where we're coaching them, we're giving them feedback. And I might ask questions. Well, have you thought about this? You told me that the patient's A1C is 13. I'm curious if the fatigue, what could we do about the fatigue? Oh, okay, we could talk to the PCP. Absolutely, we could do that. And so I might ask questions to get them thinking about other things, but I'm trying to pull the plan from the learner. And so to me, that's where I feel the confidence comes in, because this is their plan. And I'll tell them, this is your plan. This is your plan for you to then take to the patient, and then see if the patient agrees with that plan, so the patient can then make it their plan. So you're taking your plan, handing it off, and seeing if the patient's okay with that. So then it becomes the patient or family's plan. And so I find that really helps build confidence in students.
And you know what I love is it goes back to, one of my favorite quotes is that people don't fight their own ideas. And
Yeah.
how much like
Yeah.
that moment allows, as you said, like this kind of very much in the moment development of people's own ideas. And as you said, through Socratic questioning, prompting a little bit, people come to this. And like, what a cool way of, as you say, reinforcing their autonomy that, hey, you're developing this plan. I remember the other thing I like about this relatedly is we were doing some precepting recently, and one of our interns who's doing phenomenal, did a great job with the contextual interview, it was with a kid, and the intervention, again, very an appropriate kind of algorithmic based on the evidence intervention. The question was like, is it realistic for this family to do that? And it was a cool moment to be able to have that conversation. It's like, hey, well, what's the parents' context right now? Like, and again, not saying like, hey, that plan isn't going to work. It was more, as you said, Socratic question. And you could see literally the wheels turning in the intern's kind of mind. It's like, oh yeah, that is interesting. Like, maybe we can adjust this a little bit more. Like, it was a really cool moment. And almost like within PCBH, we wouldn't have if we weren't there in that moment to do.
Absolutely.
At supervision, 4 or 5 days later, you might not even talk about that situation in that scenario.
Absolutely. Absolutely. And you raised an interesting point about, you said, is this plan, quote unquote, doable for the family to do? And it made me think about health equity, social determinants of health. And we have all these great lectures and didactics. We have our students, residents, interns, fellows go through. What great moment to actually see it in practice is asking questions related to that. When they're coming up with a plan, you told me the family was food insecure, right? So walk me through how so you can actually see those things play out when, okay, are all these didactics that you're doing related to social justice actually, how you see that actually play out? And so I think I love that question you asked your intern about, is this actually feasible for the family or not? That's a question I ask every day to our interns, to really think about the layers of social determinants of health, the barriers that our patients go through. Many of our patients right now, they're at bus stops, and San Antonio is super, super hot. It's been hot, and thinking about standing outside, waiting for the bus, and then giving up. We had a patient actually call yesterday and cancel her PCP appointment. She said it was too hot. She goes, you can reschedule me back in October, even though she really needed to come in yesterday. And so thinking about all these things, it's helpful in the precepting where you can see your learners' wheels hopefully turn to think about the systemic issues that our families and patients go through.
And Stacy, as you said, like the profound, impact of now these things that we talk about regularly actually being uptaken because it's happening in the moment with the feedback. And Bridget, Bridget does a great job talking about like people's access views, whether it be the races, cultural relevance, their internal and external context, and again, social determinants of health, stage of change in their values. And what cool moments to be like, where do you think they're at in stage of change? And how would you know? Like, how would you know, like, what stage of change they're in? And even prompting that thing about like, hey, social determinants of health. And it's like, oh, I didn't even ask about those things. It's like, okay, that might be something we want to. That is a really cool way. I never thought of it that way, about how much it reinforces these things that we hope is uptaken by our trainees. Oh, that's cool. That's cool. Let me ask you this, and I know again we're getting up on time. We could talk for days
Yeah.
about this.
Yes.
What would your 1 or 2 top recommendations be for people that are either doing the work of supervision within PCBH or about to become supervisors? Like, what would be your top recommendations about, hey, make sure to do or make sure you learn, or make sure, like, what would be the 1 or 2 top things that you would want to make sure that supervisors are doing?
I would say, gosh, there's so many. Oh my gosh. Ooh, number. I have like 10 coming to my mind, but let me pick one or two. Let me pick one or
Say
two.
all 10 if you want. I
Um,
love that. Yeah.
I think number one, make sure you as a supervisor, you understand the function, purpose, nature of primary care. Because to me, that's the hallmark of what we do and why we do it and what makes us different than endocrinology, than cardiology, what makes us different than the subspecialties. We are different, just it's not a trick question. We are different in the primary care specialties. Do you know why that is the case? And can you share that with your learners? I think that's the biggest thing, just understanding the history and purpose function of primary care. Even depending if you're in pediatrics, family medicine, whatever primary care subspecialty, know your history
Hmm.
because it matters. So that would be the first thing that I would say. The second thing I would say is be a lifelong learner.
Hmm. Hmm.
Whether it's putting a plug for the supervision course, take that. But there are other courses out there. There's academic societies related to family medicine, pediatrics. They have great online courses that for the most part, they do their best to make them into professional. And so take other courses related to how to give feedback, how to design a curriculum, how to teach a workshop. These are all things that are part of our roles as clinical supervisors. And so continue to just build your craft. I think we're really good at doing that as clinicians, as researchers, but for some reason, the clinical supervisor hat kind of gets the short end of the stick. And so that's just as important as your role as a clinician. If you're a researcher, your role as a researcher. And so definitely dig into lifelong learning as a supervisor. And the third thing that I would say is something that I continue to work on is when you're working with learners in clinical settings, give them a moment to explain their reasoning for why they're doing what they're doing with the patient and family. It may be very different from what you think. And it doesn't mean it's wrong. It just means there's another way to provide intervention to someone when they're in need. So that's the biggest thing that I'll say is don't cut your learner short when you're like, well, I wouldn't do that. That's okay that you wouldn't do that. Let them come into their own skin. This is how they come into their own skin. Many times I'll think through and say, wow, I wouldn't have done that, but that's pretty cool that you came up with that. Reinforce that. So it's okay for them to come into their own. They don't have to do it exactly the way you would do it as a supervisor. As I tell my learners, I'm not creating mini Stacys. I'm
Exactly.
creating you. I'm building you up as a clinician, teacher, supervisor, whatever roles they will have in the future. So that's the last thing I'll say is let your learners think independently.
And I love how you said that, in those 3 things. So it's, knowing primary care and the history and the function and the purpose of primary care, that lifelong learning. And then this last one, and this is definitely like, I'm sure if you talk to my supervisees and my learners, this is one I struggle with the most too, right? It's like, as you said, we're not trying to replicate who we are. One, that just automatically means we're not going to iterate and get better if we're just only replicating the things that,
Exactly.
right?
Yeah.
And then how cool about not only the humility that shows, it also reinforces what you've talked about throughout this, is it builds up autonomy and confidence for these learners to come in, that they saw it a different way, and that's okay.
And that's okay.
That was cool, Stacy. That's
Yeah.
really cool. Okay, well, we'll end here. I cannot overstate for people watching this, check out Stacy's course. It is again, I got to do a live training with Stacy, and it was profound. And it definitely, when we left that, we had so many different conversations about like how can we incorporate these different things. And so definitely check out her course. And I would assume, Stacy, tell me to shut the hell up if I'm not supposed to say this, but also give feedback on these different things that come up with the course, and to go, because this obviously, as Stacy does, she's going to iterate the hell out of this. So
Absolutely.
yeah.
Yes, we have a pretty robust evaluation piece that I built into the course, so I can make updates and possible future iterations based on what people say. So if you're enrolled in it, please give feedback. I welcome it. I'm open to it.
Awesome. And obviously CFHA is coming up in a couple months. Stop
Yeah.
Stacy's life at CFHA to learn from her. She's the best. So again, Stacy, thank you so much for
Oh,
doing
thank
the
you so
work,
much. Thank you
talking
so
about
much.
this and being here today.
Thank you for having me. Thank you so much.